All right. Hi, everyone. We're so glad you can make it. Thank you all for making the time to be here. I'm Talia. I'm the Content and Community Manager here at Hugo Health Kindred. For those of you who don't know, Kindred is building a network of data-enabled people who have been impacted by COVID and who want to contribute to research in partnership with leading scientists. I strongly encourage anyone who is not yet a member to join us. You can go to kindred.hugo.health for more information, and it is from Kindred that you can enroll in the Yale Listen study led by Doctors Iwasaki and Krumholtz. We're also currently screening for the PAX-LC trial. That's for anyone with long COVID. If you have any questions about joining Kindred or getting your profile set up, your account set up, please contact me, Talia at hugo.health. I'll throw that in the chat right now. It's just a lot. Oh, I'll send it again. I sent it accidentally to the panelists and the host. But anyway, shoot me an email, Talia at hugo.health. The chat that is available now is great for talking with each other, for sharing any stories of symptom, success, seeing improvement in symptoms or finding support or anything like that, or asking questions directly to the panelists or Dr. Jim Jackson. As far as any questions about Kindred, setting up your account, enrolling in trials, stuff like that, please contact me, Talia at hugo.health, and I'll be sure to get those answered. Today, we are honored to welcome back Dr. Jim Jackson. He is going to be discussing his book, Clearing the Fog. We're very excited to have him. If you were in attendance at the last Café he was here for, that was, I think, back in October. That was one of our best cafes to date. So we're really, really thrilled to have him. We had over 150 people sign up for this event, and we're so excited that you all could be here. Today, moderating, we have Frank and Pam. You have probably seen them moderating events before. They are two amazing Kindred COVID task force members. We're so happy to have them here. So without further ado, we'll just get started. I'm going to hand it off to Pam, who's going to share a little bit about her story, and then we'll go on from there.
Great. Thank you, Talia. Thanks, everyone, for being here. Really excited to work with Frank to present Dr. Jim Jackson and his great work that he has done with his new book that's come out. I'm just going to tell you very briefly about my history with long COVID. I became sick in December of 2020. My first symptoms were loss of taste and smell, which was very common back in 2020, if you remember. But beside those two symptoms, I didn't really follow the path of everyone else that I'd been hearing about on the news. I didn't have a cough, for instance. I didn't have low oxygen, but I was very sick for about 3 weeks. And my illness was very neurological in nature. I had severe insomnia, memory impairment, cognitive issues, tinnitus, severe headache that just was 24/7, fatigue and restlessness, which I know many of us are very familiar with that now, the wired and tired, joint pain, nausea, rapid heart rate. And then I started developing this association syndrome and having auditory and visual hallucinations. So it was actually really terrifying, especially as the days dragged on into weeks. And then I wasn't sure if I was ever going to make it through. But I did. And by the end of December, I was better. I went back to work in January of 2021. But I was having episodes of fatigue and headache, nausea, brain fog, things like that. So I would work. I was working from home, so I'd work and take a break, and then work and take a break. The episodes became more frequent over the next following weeks. And by March of 2021, I was sick every day. I held on to my career until May of 2021. And then I had to leave my post as a professor at the University of Tennessee, where I was the director of my own research center. And that was very difficult. I've been diagnosed with POTS, ME/CFS, and MCAS, which I know a lot of folks on here have been diagnosed with. My biggest issues now are significant fatigue. Of course, all the things that go with POTS and ME/CFS, I get significant post-exertional malaise. I have very severe cognitive deficits and a lot of memory issues, which is why I'm reading this off of a piece of paper. And yeah, so now I'm just making it through the days. I'm hoping research is going to make a breakthrough and that we'll all see some relief. And I'm learning to live with my symptoms, working on acceptance, and just trying to have a meaningful life under the circumstances. And that's all I've got. Frank, if you want to introduce yourself.
got COVID in January of 2021, verified by a rapid test, which I thought must be wrong. Got the PCR test, same result. Much like Pam, I lost smell. I never lost taste. Mine was what I guess we can now call a mild case, and I thought I had a sinus infection. Aside from losing smell, I never had a cough. I never had a fever. Never went to the doctor other than through a Zoom call. And it was about 2 months later that I started noticing some pretty significant changes. I developed hand tremors, some internal vibrations, shortness of breath that my pulmonologist thinks is small airways disease, cognitive issues with short-term memory, but also with executive functioning and processing speeds. So, you know, it's been almost 30 months for me now with this. So that's kind of my story. It's our pleasure to welcome Dr. Jim Jackson back. Dr. Jackson, when you were here in October, you talked about that you were writing a book that was going to come out in May, your birthday, actually. And you started to tell us a little bit about that. I have a prop for anybody that can see. I guess it needs to go that way, which you signed for me. Can you tell us a little bit about the book? Just kind of an overview. And let me just say this. How we're going to do this is I'm going to ask you questions about the book itself and what you've learned and what you have yet to learn. And Pam's going to ask you some more specific questions. And then we're going to turn it over to Talia, who's going to ask some audience questions of you. So back to my question. Tell us about your book.
Thanks, Frank, and thanks, Pam. It's lovely to be with you all, and good to see all of you today. And for those joining, thank you. You know, it did come out, Clearing the Fog did come out on May 9th, which is my birthday, 55. So it was a great birthday present. And on May 11th, you know, after highlighting with the book the magnitude of the problems with long COVID, on May 11th, as you know, the federal government declared the pandemic over. And that was quite a strange juxtaposition, right? That there's a book that enters the world, very much felt like a birthing process, if you'll indulge me, creating this book that highlights the problem that is long COVID. And then a couple of days later, in the media, there's an announcement that COVID is over. And I think the book is explicitly about the recognition that COVID is not over, right? That COVID is not over. And that for many people, long COVID is a significant concern that will last for a very long time. It's explicitly about that. It's explicitly written to people who are grappling with long COVID, and it is aimed at being a very practical, frank, and empowering guide that deals with everything from how to find a provider to who you should include on your medical team to how you should take notes in a meeting with a provider if you're having memory problems, to how perhaps you can think about post-traumatic growth. And the impetus of the book, I think, was that as I was interacting with patients, you and Pam to name two, and so many others, both at our ICU Recovery Center and in our support group program, there was one thing that I thought was lacking, and that was this empathic resource, not academic, empathic, that would meet people where they were. Someone said in Goodreads, this is a long answer to your question, so forgive me, Frank. Someone said in Goodreads that the book felt like a warm hug, and the book was intended to be much more than that, far more than that. But if long COVID patients experience it as a bit of a caring embrace, I'm really happy about that, because obviously the struggle is real.
That ties in with my next question, actually. So from long COVID patients specifically, what is your feedback been on the book?
I've gotten really lovely feedback. I get a lot of emails. I don't know how many, sometimes one a day, sometimes 3 or 4 days in a row, sometimes one in a week. And I think overall the feedback has been people saying, it feels like you really get me. Feels like you get me and you understand long COVID. And I think that is due probably to the support groups for me that have been very immersive. I think people have said they find the book very practical. I've actually received feedback from a fair number of people who didn't have long COVID, who had long Lyme, for instance. I recently got an email from someone who had long Lyme who said, I don't have long COVID, but these concepts are really applicable to me as well. So a fair number of people with chronic illness, not long COVID, have reached out to me, but the feedback has been the same. And that is that the book is really practical and helpful.
Along those lines, has anything stuck out in any particular chapters or sections of the book that people say really touched them?
It's a good question, and I see in the chat, by the way, someone's asking about a brief background, and I'll mention that my background briefly, Frank, if I can.
Sure.
So I'm a neuropsychologist at Vanderbilt Medical Center. I'm a professor in the Department of Medicine in the Division of Critical Care, and I would say to some of our audience, please don't be turned off by the fact that I'm a psychologist. Some of you have had really negative experiences with mental health providers who are quick to pathologize your physical symptoms, who are quick to turn everything into mental health. I'm not really interested in doing that. I'm interested in helping people not to do that. Long before COVID, I had been studying chronic illness in ICU survivors, the effects on cognition and mental health, and to the person who asked the question, early in the pandemic, we started a support group program at Vanderbilt where we have engaged countless patients, dozens and dozens, probably hundreds, over a couple of years now. And that, I think, has helped me understand all of the aspects of long COVID. Frank, with regard to the question that is, what part of the book has been particularly impactful according to people? I think the thing that I've heard about probably the most is the thing that is, I would say, probably the hardest. And that is, a lot of people have really resonated with the discussion in the book about acceptance. Pam referenced acceptance a little bit earlier. And acceptance is something that for many people is, I would say, a pathway to healing in long COVID, is a pathway to finding a way to live a meaningful life. Acceptance is very hard, right? It's not a switch that you flip, right? It's a long, Pam would affirm, I think, it's a long process, and you kind of move out of it and into it, out of it, into it. So in the book, I talk a lot about the idea that no one likes having long COVID, that everyone wishes, me included, the patients wouldn't have long COVID, and that if the long COVID symptoms stay, one way to cope is to lean into acceptance. And I talk about the 4 A's of acceptance. Frank, the 4 A's being things like acknowledge and allow and accommodate and appreciate. Acknowledge that this is the situation you're in, allow it to be there, accommodate it, meaning make room for it, and in brief moments at least, find a way to appreciate that there's still little episodes of beauty in your life, and hopefully those will grow. So definitely acceptance is what resonates with people the most.
If there were a couple of things, before I turn it over to Pam, if there were a couple of things that you hope that readers would take away from the book, and maybe it is on acceptance, what would those be?
I think acceptance is one. I think another relates to my own journey, and I'll talk about that briefly, Frank, if you'll indulge me. One of the things that framed my writing of the book was my own battle, and it has been a battle with chronic illness, with a chronic illness that isn't long COVID, but is problematic for me nonetheless. And I talk about it in the support group, and that is that after 51 years or so, I developed OCD quite out of the blue as a middle-aged man who was, again, 50 or 51. And it caught me by surprise. I couldn't believe it. I had no idea what was going on. I went to see a psychologist and I said, I don't like this. How do we get rid of it? And she said, surprise, it wasn't quite like that, but a little bit, surprise. You're probably not getting rid of it. You're not getting completely rid of it. You've got it. So we're going to help you accept it. And I said, I don't really think so. Other people can accept things. I don't accept things. I change things, right? Like I'm supposed to bend steel. I'm not accepting things. And I think privately, she probably said, we'll see. She didn't say that to me, but I think maybe she thought it. And about a year later, I realized, this isn't going away. Maybe her suggestion to accept it is really a wise and a thoughtful one. And Frank, I say that to say that what I've learned in my own journey is that you can do really hard things, right? You can coexist with really hard things. And that's one of the insights that I would invite all of our friends here today to really reflect on. And that's one of the things that I want to highlight, that you can do really hard things. And I don't say that like a football coach, yelling at his players in summer two-a-days, right? Hey, get after it, right? I say it with a lot of gentleness. That is to say, you're stronger than you know. You've got a place where you can dig down deep. And if you can find a community to surround you, you can coexist with hard things. And I see that in your life, Frank. I see it in Pam's life, beautifully displayed. I see it in my life. And that's one of the points I want to make, that you can do hard things.
Thank you. First off, thank you for writing the book. I know it's affected a lot of people, certainly us in the support groups, but a lot outside the support groups, as evidenced by the number of people on this call. So I'm going to turn it over to Pam to ask some of the pre-questions that were received.
Thank you, Frank.
You're welcome.
Just one quick announcement. I posted this in the chat, but everyone, if you have questions for the panelists or Dr. Jim Jackson, we will have time for live Q&A. So please post that in the chat. We do not have a Q&A this time. We figured just to keep the chat to make it a little bit easier. So post those questions in the chat and we will get to them as best as we can. Thank you. All right, Pam.
Great. Thank you. So interestingly enough, you already sort of answered my first question. And of course, it was about acceptance. Some of you probably know I wrote a piece in for today.com about my journey to acceptance. And I really appreciated seeing it in the book. And I particularly loved the title of chapter 7, which was "The Wound is Where the Light Enters." Because, I was the same as you, Dr. Jackson, when the idea of acceptance was presented to me in therapy. I was not going to accept any of this. I didn't, I'm, like you said, I'm a fixer, I'm a doer, I'm not, to me, it sounded like lying down and letting it happen, but that's not what it is at all. And to me, acceptance is a perspective shift in how I view every moment of my life now. And so you've already gone over, what it means from the perspective of the book, but I just wanted to say that I really appreciate you bringing it up and writing about it in the book. And also that if anybody is, interested in learning more about it, just know that it is not a linear process. You get to a point, and, long COVID is ever changing, and you can get to a point of acceptance, and then something happens and you think there's no way I can accept this now. And then it's just sort of this cyclical process. So I'll skip that first question. So chapters 2 and 3 talk about cognitive impairment and rehabilitation and restoring. And I know this is a question that I've had, and I know a lot of other people are concerned about this. Most of us have very significant cognitive deficits, including, problems with executive functioning, memory. And a lot of folks are worried about, is this turning into dementia? And as you know, I went and got a lumbar, a spinal tap to check to see if I had dementia, because my cognitive issues are so bad that I thought there's no way that that's not what this is turning into. And it turns out that it wasn't indicative, but some of the results were a bit borderline. So I was wondering if you could speak to what you and your colleagues are seeing with regard to this turning into dementia, or is it just too early to know?
I'd love to. And Pam, I would echo, if I could, what you said about the piece that you wrote in today.com. People can find it easily enough. They could Google today.com and acceptance and Pam Bishop, I think. But it really is beautifully written, so lovely. And I would invite people to look at the piece that Pam wrote, because I think it will really enrich you. So let's talk about this issue of cognitive deficits in long COVID, because I think it's an interesting issue and it's a complicated one. And one of the things that I think it highlights that we should acknowledge is that, we use the term long COVID as if it's a thing, right? As if it's a thing. And I think what makes it complicated, and again, I think you and Frank would agree, is that long COVID varies so widely from person to person to person to person that often we're using the term, we're describing very different things, right? Some people have hugely different experiences. In fact, there's long COVID with primary cognitive problems, long COVID with primary mental health problems, long COVID with primary fatigue, right? So it's complicated, but at the risk of acknowledging it's complicated, what I would say about cognition is that for many people with long COVID, it is far more than brain fog. And I think point one might be that that's a term that I don't love particularly, because I think it minimizes the very real challenges that people with cognitive problems have. And I would liken many cases, if not most, of what we call neuro long COVID, I would liken those more to a brain injury than brain fog. There's a category of brain injuries, and I'll get to this comment about dementia in a minute. There's a category of brain injuries called ABIs. People have heard of TBIs. A TBI is a traumatic brain injury. We see people with TBIs who were in Iraq and there was an IED explosion. They had brain damage. They fell out of a tree stand deer hunting here in Tennessee. They cracked their skull. That's a TBI. An ABI is a brain injury that is generated by things like inflammatory processes, by things like being on a ventilator, by processes that could be internal to you. And I think what we see often are ABIs. And what ABIs involve, I don't want to get too academic here, is they involve a rapid development at a point in time. They largely are not amnestic in nature, as is Alzheimer's disease. And they don't necessarily get better, but they don't typically get progressively worse over time. Those are ABIs. And for most patients with long COVID, that's what we see. As someone who has worked quite a lot with people with Alzheimer's disease, as I've watched that progress in people, patients over time, mostly, the processes we see in long COVID don't seem to mimic those, right? They don't seem to mimic those. In some cases they can, but this is usually not an Alzheimer's process. And as you noted, there usually is not Alzheimer's related pathology, right? We usually don't see Alzheimer's pathology. The exception to the rule would be in some of our older patients who might have had a bit of dementia before, and it was just moving on at a snail's pace, that dementia gets accelerated. So there we see Alzheimer's disease. Some time ago, a year or two ago on Twitter, I think I said something like the following: I'm really glad that people with long COVID don't have Alzheimer's disease. And someone responded in the way that some people do on Twitter. Are you saying they're fine or something? And I said, no, I'm not. Like, I'm not saying they're fine. I'm glad that I don't see them having Alzheimer's disease. And there are a lot of cognitive problems that are not that are still really concerning, right? So we need to move away from this framing, which is either you've got dementia or you're fine, right? You can not have dementia and still have life-altering cognitive impairment, and many people do.
Yeah, well, and I really appreciate that explanation as someone who has very significant cognitive issues that, so much so that, I pursued a very invasive procedure to rule it out, I guess, or rule it in. But fortunately it was ruled out. So I think that probably puts a lot of people's minds at ease who are dealing with
Yes.
this sort of thing. So my next question is relative to chapters 4 and 5, where you talk about mental health and the challenges that a lot of us are facing, myself included. And I love also the chapter title, The Only Way Around is Through. It really speaks to my own long COVID mental health challenges. I had never experienced any sort of mental health challenge before I got sick. And in about 7 months in, I developed significant depression and I was suicidal. And fortunately, I sought help and have been continuing to seek help and improved. But here lately, I've gone through another, dark valley. And this is the process, right? It happens with so many of us that we are, in a very bad place, and then we get out of it, and then something else comes along, and you start struggling again. And I'm just wondering what advice you can give to listeners right now who might be struggling with their mental health, and especially with suicidal ideation. What would you say to them as just a first step, how to deal with this? It's very overwhelming on top of all of the physical symptoms, and I understand just as well as anybody how it can spiral out of control pretty quickly if you don't do something.
Yeah, thank you. I would mention there is an Audible version. Someone asked that in the chat of the book. And I know that because I read it and I thought, how hard could this be reading a book? And they put me in a studio. And before long, the producer was saying things like, take 15, take 16, take 17. And I was thinking, oh my gosh, what's going on here? So there's an Audible version. But to your really thoughtful point, Pam, let me say a few things. That quote, "The only way around is through," originated with Robert Frost, the great poet who hails from not too far away from Connecticut, up in Vermont, I think. He's long gone now, Robert Frost. But the only way around is through. And I think what that quote is meant to mean is that there are no benefits that really accrue when we avoid dealing with these difficult issues, right? For our purposes, these mental health issues. In the book, I share a lot of anecdotes, and people can decide whether they love those or whether they hate them. I think they're rich and useful, but there's an anecdote that rings true to me. It is true to me, and may ring true to you, and that is that I had a little Mazda 323. We moved to California. We moved to Tennessee from California in the early 2000s, little Mazda hatchback. And one day the check engine light came on that thing. And I was just busy. I was a resident at Vanderbilt and the VA. And I thought, I have time to deal with this. I'm in a hurry. And so I had a note card in my car for some reason. And I put the note card over the check engine light, and I just kept on driving. Just kept on driving. Didn't think much about it. Actually, I did think about it, and I just pushed the note card on a little harder, And one evening on the west side of town near Costco, Costco didn't exist yet, but where the Costco is now, my car died on the side of the road. Right, the engine overheated, blew a gasket, whatever, and I sold it. The car wasn't worth much, but I sold it the next day to a scrapyard for $50. And that was really discouraging. I was frustrated. My wife was. And that pattern of avoidance has been too common for me in my life. And I think when mental health problems emerge, often people with long COVID avoid them for a couple of reasons. One, I think they're often worried, and rightly so, that if they go see an internist and say, I'm really feeling some anxiety or I'm feeling some depression, they're worried that provider will say, aha, that proves my hypothesis, right? That this is just in your head, right? They're worried about being stigmatized. So they're reluctant to engage it. And I think often they also avoid it. They're not unique in this because they think, if I don't deal with this, it's just going to get better on its own, right? And and I know that often mental health doesn't work that way, right? It doesn't necessarily get better on its own. A lot of things don't get better on their own. And what I would say to the people listening here is that if you're having mental health struggles, one reason you should consider pursuing treatment, and by the way, having mental health struggles is very normal, right? Your life has been turned upside down. You've had profound losses. It's very normal. If you're having mental health struggles, be aware that if you get the right treatment, it can be really effective. And that, I think, is the best kept secret in town. I'm sad to say that is, if you get effective treatment for depression, depression usually improves. If you get effective treatment for anxiety, for PTSD, for OCD, it gets better. In my book, I outline how you can find the right provider. And I would say if people are grappling with finding a provider, not easy, reach out to me at Vanderbilt. We'll get our social worker on the case and we will help you find a mental health treater.
Yeah, thank you. And and everyone, Dr. Jackson means that if you reach out to him, he will help you, which is one of the amazing things about him. Frank and I have been in his support group since its very first meeting in April of 2021. And we've had countless group members that have been at a loss of where to go next. And Dr. Jackson and his team have guided them. And we really appreciate that. I just want to add
Pam,
to
let me mention, Pam, forgive me, let me mention suicide as well, because you mentioned that in your question, and I think it's important. Talking about suicide in the context of things like depression, feeling suicidal thoughts, it's very normal. It's very normal. It's understandably scary. Talking about it, this is important, will not make it more likely to happen, right? You're not conjuring it into existence. Talking about it will make it decidedly less likely to happen. And if you go and see a mental health provider, this is a fear, I think. I think people are afraid that if they say, I'm having thoughts of ending my life, that someone will push a red button under their desk and a man will come in with a net, right? And you're going to be on your way in handcuffs to a psychiatric hospital. That's a concern that people have who are not familiar with the way this works. And I want to dispel that a bit and say to people here, if you talk to a provider about having suicidal thoughts, their goal is not to unnecessarily send you to the hospital, right? They're going to listen, they're going to affirm you, and together you can develop a safety plan. If you're having thoughts of harming yourself, tell somebody, right? Don't hold it in. That's the most dangerous thing you can do.
Yeah. And if you don't have a therapist, telling someone that is close to you, that you love, who cares about you, is your next best thing. I have to agree with that. Telling my husband was a huge hurdle. I didn't want to tell anybody. But once, you start that conversation and all you have to say is, hey, I need to tell you something. I've been struggling mentally, and that opens the door, and then you can talk about it. And it's not as hard as it sort of feels like it's going to be before you do it the first time. And then after that, I have a circle of accountability, basically, that I tell these people that I'm struggling, and I just want to let you know this is happening. And yeah, I think it takes a little bit of the power away from it, honestly, for people.
It does. Yeah, it does. And the other thing I would say, I mean, many people on this call have families, spouses, or sons or daughters, husbands, wives, cousins, uncles, aunts, neighbors, whatever. But they often will say, I don't want to tell them that I'm struggling because I'm afraid that it's going to worry them. Well, yes, right? It will worry them, right? It'll worry them. And typically what will happen is you'll grow closer together as a result. So if you've got a spouse, let's say, that cares about you, you care about them, yes, they may be frightened, sure, but at the end of the day, it's going to lead to a deeper quality of intimacy if you're able to talk about these struggles. And that deeper quality of intimacy is going to work against things like committing suicide.
Mm-hmm. Yeah. And I think, also we're so good at putting on the mask and, when I told my close friends this week that I'd been struggling, they said we had no idea. And I said, well, that's because we don't let people know, and you have to tell them. So anyway, I really appreciate that response to this really, really important topic. I don't think mental health challenges are talked about enough in the realm of long COVID, but certainly a lot of people are struggling. So that was my last question, and I was going to turn it back over to Talia and take questions from the group.
Thank you so much, Pam. Those incredible questions, Frank, too. Really, really, really amazing stuff. Thank you. And thank you, Dr. Jackson, for your incredible answers. Once again, we have so many questions in the chat. Thank you all for posting those. We will get to as many as we can tonight. So I'll just get right into it. I apologize if you hear or see cats. I have 2 cats here that need constant attention. So they're just being them crazy selves. Here we go. All right. There's a bit of a conversation going on about vestibular therapy. So I wanted to ask Dr. Jackson, do you believe it's helpful? Do you have any thoughts on that at all, or any experience with that?
Yeah, so vestibular therapy is not my area of expertise. I would just say anecdotally, I've had many people say it's quite helpful, but I can't really speak to it, Talia, beyond that.
Okay, thank you. One question, is there a way to get involved in that support group? Is it accepting new members?
We've got a long waiting list. We started these support groups. Frank or Pam might be able to tell me when we started the OG group. I'm not sure. I will pick the date out, but it's been some time now, and then we added another one. We're in the process of adding actually another one now. So we've got a waiting list of about 50 or 60 people. However, we'd love to add someone to that waiting list. We'd love to connect someone with other resources that might be available. There are some other support groups around the country that are comparable to ours. So if the person that asked that question wanted to send me an email, we're glad to get them on the list. We're glad to move them up as aggressively as we can, and we're glad to help them find treatment somewhere.
Thank you. That's great. We have a question from Roseanne. I'm 65 and I've been struggling with long COVID since March. When I try to talk about my symptoms with friends, especially my brain fog and fatigue, those my age say the same thing happens to me, which is so dismissive, and it diminishes my long COVID struggles. This is more profound than age-related cognitive decline or general fatigue. How should I handle this?
I think it is really frustrating. I mean, Rose, in my case, I have OCD, and so similarly, people will say, as you know, oh, I'm so OCD, right? You're like, well, yeah, but not really, right? I hope you're not really. So I do think it's frustrating. One thing that I might recommend, Rose, if you're inclined, is I might recommend that you get neuropsychological testing. Neuropsychological testing is a little different than what you would get from a neurologist. Many long COVID patients that we've seen have had frustrating experiences with neurologists. I would say that might be the specialty that people have been frustrated with the most. And it's not because neurologists aren't amazing, but it's because MRIs, for instance, typically are negative in people with long COVID. And often in bedside exams, people don't have obvious cognitive deficits, but in the context of neuropsychological testing, they do. So I think, Rose, if you got cognitive testing, it would give you very detailed information. It would tell you that you have deficits in working memory or executive functioning or processing speed. It would tell you how severe those deficits are. And I think you could potentially share that with your friends to convince them, if you felt the need to, that these problems were in fact real. There also is a lot of literature, published studies that show things like loss of brain volume in people with long COVID, including people who were not hugely sick. So we'd be glad to pass some of that literature on to you if you wanted to share that with your friends.
Thank you. And this is a question for, I guess, essentially caregivers of people with long COVID. Any resources you recommend for partners of people with long COVID to help us not only understand it better, but also help the person impacted by it?
It's a great question. I don't, I think at Little Brown Spark, that's the publisher of my book. I think they really like me and I really love them. I think if they knew how reluctant I am to promote my book, they might not be too happy with me. Actually, I have a hard time promoting myself and the book. And so I'm not inclined to do that. But in response to that question, I would say, I think for caregivers, the book is really useful. It gives a practical picture of what long COVID looks like. And it also includes a lot of information for family members about how to cope. So I might direct this questioner or others to the book because I think it's very useful for family.
Thank you. And then we have a question from Sherry. I'm dealing with having incurred an adverse reaction to the COVID vaccine. It's been 30 months now. Dr. Jackson, do you feel that those of us who have been vaccine injured are dealing with the same things that a long COVID patient is dealing with?
I think certainly the clinical presentations have a lot in common. Clearing the Fog is the name of the book. I think the clinical presentations are very similar. Obviously, the mechanisms are different, but the clinical presentations are similar. And in the case of cognitive problems, there's tremendous overlap. We alluded a little earlier to the idea that this is not brain fog as much as it is a brain injury. And one thing that I like to gently suggest to people with long COVID and to people with cognitive problems due to being vaccine injured is cognitive rehabilitation. I think it often helps people in either category, and it certainly may help you too.
Thank you. We have a question from Gary. How does neuropsych testing differ from cognitive evaluation?
So neuropsych testing, Gary, might be a fancy term for cognitive evaluation. It kind of depends. So when we think of cognitive assessments, we think of a couple different things. We think of abbreviated screenings, and we think of kind of moderately comprehensive batteries, and then we think of truly comprehensive neuropsychological evaluations. So often if you go to a clinic, depending on the healthcare system, you'll get a test called the MOCA, or you'll get a test called the MMSE, the Mini Mental State Exam, or someone might ask you to draw a clock. It's not that those tests aren't useful. It is that in many people with long COVID, the deficits are subtle enough that they don't necessarily show up on those evaluations. And people are frustrated because they're told, you know, you got a 30 out of 30 on the MOCA. What are you complaining about? You seem just fine. So I think you don't want that. I don't want that for you. And a more appropriate course of action, often covered by insurance, is a neuropsychological evaluation. That typically is going to assess a range of domains, just off the cuff: attention, aspects of memory, working memory in particular, immediate and delayed memory, something called executive functioning, processing speed. It's going to assess language, because as we know, people with long COVID have some language problems. It's going to evaluate visual spatial functioning, and it probably is going to take 3 or 4 or 5 hours. And if it meets those criteria, I'm going to call that a neuropsychological evaluation. And I'm going to imagine that that probably is definitive enough to get at the answers you're looking for.
Thank you. And then we have an interesting follow-up on the neuropsych. I had a neuropsych testing when first injured over 2 years ago. Do you recommend repeating testing after a certain time frame? And that question is from Nicole.
Yeah, hi, Nicole. Thank you for asking. I think it's not a bad idea. I think if you're curious about what has transpired over that 1 or 2 year period, to do a repeat assessment is a very reasonable thing to do. And that could show a couple things, of course. It could show no improvement. It could show substantial improvement. It could show that you were getting worse. And any of those scenarios, learning about any of those scenarios would be useful to you. So if you have insurance, you have the resources, I think repeat neuropsych testing is just fine.
Thank you.
I'm seeing a lot of questions, Talia. Oh my gosh,
Yes.
81, amazing.
Yes. Next question from Amy. My husband is an amazing caregiver, but he needs support too. Are there any support groups out there for caregivers? It's a great question, Amy.
It is a great question, Amy. We have one. We have one at Vanderbilt for caregivers of people with long COVID. And currently, that group largely involves spouses of people who were critically ill in the ICU, but not only that. So we may have some room in that group. And if you want to reach out to me, we'll be responsive. I noted, I'm kind of monitoring the chat here as I'm talking. I noted that someone someone chatted and said they had reached out to our group or maybe even to me a couple times and had not gotten a response. I'll apologize for that. Not sure how the ball was dropped, but we'll fix that. We'll make that right. That's not our practice. So if you're interested in learning about our caregiver support group, reach out to me. You can find my email easily enough. They can provide it. That's fine. And we'll see what we can do.
Sorry, I muted myself.
Oh, good. I thought, oh no, I lost sound.
It's just me. Next question is from Gary. Insurers are finding every opportunity available to deny neurologically based problems stemming from COVID. It is very difficult with this impairment dealing with the denials. Is there an online source that links the correct IDT-10 wording for neuro long COVID PCPs to use in their workup for us, so we, as patients, are not constantly inflamed by the insurer?
Couple comments about that. I don't disagree with that. I mean, I recently was helping a patient of mine pursue disability, a long-term disability claim. Frank's an attorney, and so he knows how these things work. And one of the insurance adjudicators, if that's the right word, had gone on social media and had noticed a picture of my patient looking happy at an event and had said, we're concluding from that you're not really depressed, right? So that your brain's not really injured. And that's not a one-off. I mean, I've seen that in many cases. So I agree, it is really difficult. I'm not sure what the best resource would be with regard to a particular ICD-9 code. I would say when we have had people pursue claims, we have not had to use COVID specific numbers, if you will, or references in the letters that I'm advocating. Whether you have COVID or not, cognitive impairment is cognitive impairment. So many of our patients have diagnoses of cognitive impairment not otherwise specified. That's a common one, not the only one. But I don't think COVID-specific nomenclature has to be used to pursue some of these claims. It's cognitive impairment.
Thank you. A few questions about ABIs. One from Steve: how can I get an assessment for an ABI? Do I ask my PCP for a referral to a neurologist or another specialist? And then Jamie asks, can an ABI be seen on an MRI?
So I would always encourage you, not always, right? It's an individual decision, and your provider, if they have a strong opinion related to one or the other, listen to that. But I would often encourage you to start with the neuropsychologist and then transition to a neurologist, partly because that neuropsychologist is going to give you information that is a little more actionable, very likely, and they are going to tell you whether they think you need to see a neurologist. Probably you're going to get more information that you can use from that neuropsychologist. So if I was asking for a referral for, again, an acquired brain injury, I would say, Dr. Smith, could you refer me to a neuropsychologist? And I'm sure they'll be happy to do that. As for the second question, sometimes we see acquired brain injuries on MRIs. Sometimes we don't. Often what happens, and this is a frustrating thing, is patients go to see a neurologist, they're referred for an MRI, the MRI is negative, the implication in the process is, hey, actually you're fine, right? Your brain is just fine. And I would invite other providers not to arrive at that conclusion too quickly And I would encourage you to use your own insights to draw some conclusions about whether you're impaired or not, right? Like increasingly, I think we're doing a better job relying on the feedback of patients. I don't have to have a positive MRI to take my patient's claim seriously, right? And your provider doesn't need to have one either, or they shouldn't.
Thank you. Next question from Jamie. Dr. Jackson, there are a lot of treatments that people are doing, such as triple therapy, vagus nerve stimulation, nicotine patches, or the shot that Dr. Grossman gives you in your neck. Do you think any of these work?
I don't, as a general rule, I don't know how well those work in the cognitive realm. If we confine it to that, what I know works, because I see it a lot, is cognitive rehabilitation. Does it work as completely as everyone would like? It doesn't necessarily, right? Will it change the course of your life? Maybe not. Can it improve things reliably? It can. So I do like to recommend that. There was a paper published by one of Leslie and Harlan's colleagues, two of them actually at Yale, not too long ago, using guanfacine and NAC and NAC for long COVID that had a cognitive component. Some people respond well to that. Some people have indicated they don't. You know, this is very individual. But if you were my next door neighbor or my brother or my husband or wife, whatever, and you were having cognitive problems, the first thing I would recommend is cognitive rehab, just as the first psychotherapy I would recommend in general would be something called acceptance and commitment therapy, which is particularly potent for people with chronic illness.
And then we have a follow-up question for that. How do you get into cognitive rehab?
So there's an episode, if people want to find it, should be easy to find. NPR has a show, Fresh Air. Some people have heard of Fresh Air with Terry Gross. Unfortunately, Terry Gross was out the day they interviewed me, so I didn't get to meet Terry. But I was on Fresh Air. Again, you can find it online on a podcast, essentially. And I talk at great length about cognitive rehab. In general, Talia, the experts that do cognitive rehab are called SLPs, or speech and language pathologists. Sometimes occupational therapists do cognitive rehab, but generally SLPs. People get thrown by the term speech and language pathologist because they say, my speech is fine, right? My language is fine. We're not implying that you have problems with your speech. It just happens to be the case that those are the experts that have a particular faculty in cognitive rehab, SLPs. I refer people to SLPs around the country all the time. Just referred a patient that reached out to me to an SLP in Washington, D.C. just last week. And you can try to find one. If you can't find one, we will help you find one.
Thank you.
I'm committing our social worker to a lot of tasks, by the way. I'm aware of that, but she and I will hash that out later.
The next question, we might have time for one more after this. This is from Jeff. Dr. Jackson, do you have any advice regarding communicating with a spouse or support person who seems to have compassion fatigue?
Yeah, I think it's a real phenomenon, compassion fatigue. And I think that is where COVID overlaps with many other chronic conditions, right? We're spouses of people with lupus and cancer and chronic fatigue and 101 other issues have compassion fatigue. And I think we can learn from those communities. We can learn about how they navigate compassion fatigue. One thing that helps solve the problem of compassion fatigue, I think, is if a spouse can engage in self-care. Often spouses put their lives on hold very lovingly to care for people with long COVID or any other chronic illness. And while that's very touching and beautiful, at a certain point, if they're not caring for themselves, that generates frustration, resentment, even bitterness, and that's what we don't want. So inviting your spouse to engage in self-care, I think, is important. And I think this is one more argument, if you will, for why therapy might be important, because often, if you're not engaged in a support group, if you're not engaged with a therapist in a community, you're taking all these challenges you have, you're placing them squarely on your spouse. That's a lot for them to carry, right? Even if they say they can. So make sure that you're widening your support network so that it isn't solely your spouse. And I think that is hopefully going to decrease compassion fatigue.
Thank you. We have time for one more question and then we'll wrap up. This is from Michelle. If outpatient cognitive rehab 1 to 2 times a week didn't help a lot, would you expect more intensive therapy, such as through a multi-week day rehab program, including speech, OT, PT, and psych would be more helpful?
I think it could. I think the answer is it could. Michelle is the questioner. Michelle, if you want to reach out to me, glad to talk to you about it. There's a beautiful article in the New York Times. Want to say it's from 2021 or so, by the New York Times COVID writer Pam. Her last name starts with a B. I can't remember the name right now. I can't believe I'm blanking on it. But the New York Times beat writer, long COVID beat writer Pam, wrote a lovely story about a patient named Samantha. And Samantha had long COVID, not a hugely severe case. And Samantha went to a very intensive kind of quasi inpatient cognitive rehab program at the Shirley Ryan Ability Lab in Chicago. And this beautiful article in the New York Times, Talia, I can pass it on to you and you can share it somewhere or other, details Samantha's experience with multimodal cognitive rehabilitation and how it really transformed her life. I was at a conference with Samantha, parenthetically, at the University of Southern California, and I really came to enjoy her. And about a year ago, we were dropping my son off at college, and we were at a restaurant in Illinois, and I said to my wife, I know that person, I know her. And Michelle said, really, Jim, that's a little random. And I said, that's Samantha. Sure enough, there was Samantha. And she's really doing very well due to this multimodal cognitive rehab program. So I think if you have the resources, I think it's worth a try.
Thank you so much. And that is time, everyone. There are so many more questions. We will, again, save them, try to get them in any kind of way that we can. If you want a copy of tonight's chat, please email me. It's talia@hugo.health, and I will be able to send over a copy of the chat for you. If you are looking for a way to contact Dr. Jackson, Pam kindly put his email address in the chat, so you can look at the chat for that as well. Or if you want to email me and I can connect you, that also works. Just want to thank everyone so much for their time tonight. Dr. Jim Jackson, of course, thank you so much for being here. This was another incredible event. We hope to have you back again in the future. Pam, thank you.
So lovely, Talia. And I really hope that, and now maybe tomorrow I'm trying not to check my email after hours quite as much, but I really hope that when I log into my email that there will be a flood of questions that we're really happy to engage, and it'll be our privilege to engage.
Thank you. That's amazing. Thank you. Pam, thank you so much for coming, for being a part of this tonight, and for your incredible questions and for sharing your personal story. Frank, you as well. Thank you again for being an amazing, amazing panelist, as you always are. Everyone, our next Kindred Cafe will be on, I think it's September 28th. We have it. Yeah, September 28th. It's a Thursday, 5 o'clock to 6 o'clock. It's another fireside chat with our patient advocate task force. This is more of a support group like setting. It's a great place to ask for peer advice on symptom management and finding support and stuff like that. And then we also have a Listen Town Hall coming up October 19th. You have to be a Listen member to join. You can still join Listen. Just log on to Kindred and find it under Kindred Research Studies on the right-hand side of the homepage. Again, if you have any questions about anything at all, please contact me, talia@hugo.health. I'll be happy to get to those. And thank you again so much for being here. This is an incredible, incredible community.
Thanks, guys. Bye-bye.
Thanks, everyone.